Welcome back to Pharmacology with Dr. Sokolow, and today's lecture is about pain, and in this module we are going to talk about the use of opioid for the treatment of pain. So as I said, we're going to start with the opioid analgesic. So first of all, what is pain? So I think everybody in this class know what pain is. So it's an unpleasant sensory and emotional experience. It can be acute due to recent injury, like you cut yourself, you fall from a bike, or it can be chronic due to an injury or a disease such as rheumatoid arthritis, so RA, or cancer. Unfortunately, in the United States, many elderly live with chronic pain and some may die with uncontrolled pain. So it's a really serious problem, pain management, and something that is not easy to control because we cannot be in the self of the patient, and it's hard to determine the exact level of pain they are in, even though we use the Wong-Baker faces, like the pain rating scales, to kind of assess how they feel, on the scale of 0 to 10. Are they a little bit hurt somehow, or is it the worst pain ever? So healthcare provider, we are concerned about the inadequate pain treatment, but also about the side effect of those medication, whether it's opioid or NSAID. And of course, with the opioid, we're concerned with the abuse potential of those drugs. So the Joint Commission standards require that pain be treated in the same manner as vital signs. So pain is considered as the fifth vital sign, and the assignment of the pain, it's important also to determine the type of pain. Is it a burning pain, a shooting pain, the timing, when does the pain occur? Is it all day long, if it's acute or chronic? And also the severity of the pain using the pain rating scale. So the opioid analgesic, so opioid refers to the drug with action similar to morphine, and they are ligand for the opioid receptors, and there are three types of opioid receptors. You have the mu, the kappa, and the delta receptors, and or endogenous opioid, the one that we produce, that our body produce, are the endorphin, the enkephalin, and the dynorphin, and they bind to all three receptors. In terms of clinical relief of pain, the mu receptor are the most important, and the opioid drugs, they are primarily activating the mu receptors. The term opiates apply only to the alkaloid in the opium plant. So when you hear about narcotic and police talking about opioid, they really refer to the opium plants and the derivative from the opium plant. Now, medication, so the opioid analgesic, they are controlled drugs, and I'm going to show you in the next slide the different type of scheduled drug. And I also have here the list, the link to the Justice Department and Drug Enforcement Administration with the definition of all the different schedules. So in terms of classification and controlled substance, you have Schedule 1 to 5, 1 being the drug with the more potential of abuse. So these are the most dangerous drug of all drug schedule, with potentially severe psychological and physical dependence. And this includes heroin, marijuana, ecstasy, and other, street drug. Now, Schedule 2, they have a high potential of abuse with use, but and their use potentially leading to severe psychological or physical dependence, and these are considered dangerous. And so here you have Vicodin, that is now a Schedule 2. You have cocaine, methamphetamine, methadone, hydromorphone, oxycodone, fentanyl. So you see all the opioid analgesic are in there. And for the history, Vicodin and OxyContin used to be a Schedule 3 drug, and until it become a real serious problem in the market, because those drugs were scheduled drug, and I mean they are controlled drug, and even though they were Schedule 3, they were the #1 prescribed drug in the United States for a very long time. And so now they are Schedule 2 instead of Schedule 3. And the difference is that when it's the Schedule 2, the patient cannot have refills anymore. So every time they want a refill of their prescription of OxyContin or Vicodin, they need to see their provider. So they cannot have a prescription for 6 months where, several refills every month. They need to have a new prescription every month to get their medication, which makes it more complicated for those who really want to abuse those opioid analgesic. When it's a patient who is in pain and really need the drug, that's not a problem, but that kind of to discourage those who were using more because of dependence. Schedule 3, so they have drug with moderate to low potential for physical and psychological dependence. So it's, a little bit less dependence with Schedule 3 drugs. And here you see you have ketamine, testosterone, anabolic steroids, and some product that contain less than 90 milligram of codeine. Then you have Schedule 4 drug with low potential for abuse and low risk of dependence. You see you have Xanax, Valium, so these are the benzodiazepine drug, and we'll talk about this in the central nervous system lecture. And then you have Schedule 5, which are the drug with lower potential for abuse. Then, Schedule 4 drugs, and in there you have Lyrica, you have Lomotil, Motofen, some cough preparation containing less than 200 milligram of codeine. So Schedule 1, the highest risk of abuse, and Schedule 5, the lowest risk of abuse on those scheduled medication. Now, here, this is a table that is from Laney, and you see the action of the different opioid agonists. So you have the pure agonist, which are morphine, codeine, meperidine, and other morphine-like drugs. So you see they are agonists of the mu receptor and the kappa receptor. And then you have some that are agonists, antagonists. So they are partial agonists. If you remember your concept from last quarter. So buprenorphine, you see it's a partial agonist of the mu receptor, so it has some agonist activity and antagonist activity at the same time. So it has an intrinsic activity on the mu receptors, and it's an antagonist, pure antagonist of the kappa receptor. And then pentazocine and butorphanol, you see they are antagonists of the mu receptor, but they are agonists of the kappa receptor. And then you have the pure opioid antagonists such as naloxone, naltrexone, and nalmefene. And these are very useful when there is toxicity caused with the opioid analgesic, or patients who are drug addict and using heroin. So these are the drugs that are used to reverse the effect of the opioids. So here is another classification of those opioids. So you see you have the pure opioid agonist. So you have the full agonist, the strong agonist. So morphine, of course, is the most commonly used opioid analgesic in practice for severe pain. So you have morphine, and then you have hydromorphone, oxymorphone. Methadone has a long half-life, and so this is a drug that is used in patients who are addicted either to heroin or most likely to heroin, but it can also be used to the treatment of opioid addiction because of the long half-life. So you don't have the withdrawal syndrome that you have with other opioid analgesic. Then you have fentanyl, very, very potent. That's the most potent opioid analgesic, and meperidine, and those have short duration of action. And so these you have to be very careful when you see fentanyl in the hospital. So this is a higher drug, because if you miss the dosage with fentanyl, that can cause lethal, can cause death to your patient. And then you have the mild to moderate agonists such as codeine. and it can be used with or without acetaminophen. So when they are combined together, it's a more potent combination than acetaminophen alone, so than Tylenol. So it's Tylenol 2 because it has codeine with it. Then you have hydrocodone with or without acetaminophen. So hydrocodone plus acetaminophen is Vicodin. And as I said, it was the most widely prescribed drug until not so long ago. Oxycodone and acetaminophen are the active ingredient of Percocet. So fentanyl, as I said, is a very potent drug, and it comes, IV or as a transdermal system, so transdermal patch. It reaches effective level in 24 hours. However, you don't replace the patch after 24 hours, but you replace the patch after 72 hours. Very important not to put a patch every day, because overestimation of the fentanyl dose can result in fatal overdose. And it's indicated, so FDA approved only for persistent pain in patients who are already opioid tolerant. This is not for patients who are opioid naive. It's contraindicated for children under 2 years old and adults that weigh less than 110 pounds, because this is very, very potent opioid analgesic. It's not indicated for post-op, not indicated for intermittent pain or pain that responds to less powerful agent, because as I said, this is reserved for patients who are already tolerant and who needs, something, very strong, usually cancer patient in their terminal stage will be on fentanyl patch, but not for opioid naive patients. Methadone has, as I said, has a very long half-life, and it's used as maintenance therapy for patients who were addicted to heroin or other opioid that they were snorting or doing anything with. It's prescribed once a day, and they would start with a high dose, and then they will taper them down, and patient can be maintained for decades on methadone. Here in the United States, the prescription is restricted to opioid treatment programs that are approved by the state and federal agency. Myself, when I was working in a pharmacy in Belgium, I was seeing methadone patient in my pharmacy practice. It didn't require to be approved by the state or the federal agency, and the methadone patient were coming sometime every day and drink. We were making syrup to make sure that they were not injecting their methadone, and they were drinking in front of us at the pharmacy, so we could control that they were taking the dose. And once they were once we knew the patient and they were like on a long-term treatment, and they switch usually from a suspension like a syrup to some capsules. And so in the capsule we were also adding some ingredients that would swallow in their vein if they were trying to inject it. And tapering the dose, and then they were having like normal life and being on a chronic daily dose of methadone, and that would prevent them from relapsing and doing street drugs or heroin injection. Now, other opioids, so we talk about the full agonist. Now we have the one that has a mixed receptor action, so the mu partial agonist and the kappa antagonist, such as buprenorphine. So it's a partial agonist of the mu receptor, and it's also used as a treatment strategy for addiction. When it's administered alone, so it has the agonist antagonist opioid effect that produce analgesia. But when it's given to a patient who is taking a pure opioid agonist, so let's say if it was a patient who was on heroin, the agonist antagonist opioid can antagonize the analgesia caused by the pure agonist, or can precipitate the withdrawal reaction in those that were physically dependent on the pure agonist. So, again, use as sometime treatment for patient in rehab. And then because of the effect that is a partial agonist and antagonist, it has a low potential of abuse. Now you have the pure opioid antagonists such as naloxone, nalmefene, and so naloxone is the prototype, and these agents are um, used in overdose situations. So patients who are coming, either from the street, found on the street doing with overdose, brought to the ER, and then naloxone will just reverse the effect of the pure opioid analgesic and revive your patient and brought them to a state that can be managed. Now here is a conversion table of those different opioid analgesic. Very important not to give the same dose when you convert your patient from the IV to the oral, because the opioid analgesic has a high first pass effect, so you have a higher oral dose compared to the IV dose. So always make sure that when you convert your patient from the IV to the oral, that is not the same dose. You want to double check on that. I'm not asking you to know the oral conversion, but I want you to be aware that the IV and the parenteral dose is lower than your oral